Anne-Berit pointed out to me that you got this title 2 years ago, but now I'm going to give a different lecture this time. Not that I changed opinion so much, but I didn't remember that I was given this title, so I started anew, and I think it's a good idea. Otherwise, you just repeat yourself. This is a chart over the guidelines that we have at Karolinska Huddinge, where I work. And I will take you through the guidelines, why we are doing this, and also the arguments for that. So this is how it is going to be today. ICU admission. Is the patient suitable for the nutritional protocol? I mean, there are patients who are not suitable for it. They may have a very low body mass index, or they may be have been adapted to starvation for various reasons that we may deviate from the protocol. They may have funny or very rare inborn errors as well. But taken over the year, we admit approximately 1,000 patients to our unit in Stockholm, and we are talking about less than 5 patients per year who will go out of this protocol for these odd reasons. But I like to point out that these 5 patients are where you may do mistakes, which may be problematic. First thing is that we do selenium. We consider if patient will have insulin, and we will give a caloric target. This is when you write the immediate chart for the nurses what to do. Luckily, selenium will be discussed by Professor Berger, so I leave that. But we live in a low selenium area in the world, in Scandinavia, just like northern part of United Kingdom and things like that. Many of you in the room may live in parts of the world which are rich in selenium, and then it becomes differently. We consider insulin. We have not a normal glycemic target, but a next to normal glycemic target, which is, I won't discuss in detail here. The protocol to try to stay within limits is nurse-driven, and basically you prescribe the target and a dosage, usually up to 10 units of fast-acting insulin per hour in the. And then we give a caloric target. Usually when we come to unit, it's not possible to do indirect calometry immediately. So if you can't do that, you still put up a target. And if you just have to take a value out of the air, you take 20 kilocalories per kilogram. And the kilogram then becomes the issue, basically. How do you know what is the kilogram? And the formula we have is that we take length minus 100 plus 1/3 of the difference between that and the actual weight. So the overweight of the patient, 1/3 of that we consider to be valuable tissue, if I put it that way. This is how the kilograms are calculated in our unit. It's not very scientific, but you got to have some way of deciding upon this plane. This target, which on the next few days probably will be challenged by an indirect calometry in our unit, this should be received on the 5th day according to our protocol. It may be reached earlier by enteral nutrition, but we will definitely not add parenteral nutrition until the 5th day. And then you come to these discussions. I mean, this is a study from Lausanne, which Mette is a part of, which has been widely cited and been very important. It illustrates that you have an energy deficit in relation to a target, which in this particular case is a little bit high according to my standards, but nevertheless, it was a target. And during the first week, they didn't reach the target, and the accumulated energy deficit was related to a lot of adverse effects, outcomes, if you want. So there are several studies of this, which guided us to start full nutrition from day 1 or 2 earlier. We don't do that anymore, as you found out in our unit. We do it in some patients who are possible to feed by enteral route. I come back to that. In parallel, there are publications like this from Krishnan, which show that this is the spaghettogram here illustrates what happened to these patients in a medical ICU somewhere in North America. And the patients in the middle third had the best ICU survival. Not the ones fully fed, not the ones poorly fed, but the ones in the middle. Anne-Berit cited Arabi, which is another study. I can easily point out shortcomings in this study and in the Arabi study, but nevertheless, there is a documentation also for other targets beside the accumulated energy deficit. So at the end of the day, we are lost with different interpretation, and all of these studies have partly selected patients, which basically is a problem into this. You should really take care of consecutive patients if you are doing anything like this. Now we come to the consideration: is patient in hospital admission or is it an emergency admission? If they are in hospital admissions, they may be on a feeding protocol from where they come, but the reason to come to ICU is usually that they are deteriorating one way or the other. So this is how we look upon patient, and I will start to discuss the in-hospital admissions, and they may be on parenteral, they may be on a combination, or they may be on enteral nutrition. And if they are on parenteral nutrition, and now I will tell you how we handle, I will try to stay away from brands and things like that, but in principle we use a standard all-in-one formulation, and if you look on the different brands that are available on the market, they have some variability in the fat, carbohydrate, and amino acid caloric ratio, and also the protein to calorie ratio. So basically you must make up your mind how you would like to handle this. Because whether you do it per kilogram body weight, 20 kilocalories in the early stage, as I said, or if you do indirect calometry, you will start to give very different proteins or amino acid contents, and you have to find out how you will deal with this with your patients. I will discuss that briefly coming up. If we look upon the fat, there is a lot of advertising on this point, but if my interpretation of available data is that there is no solid evidence for difference in outcomes of critically ill patients related to type of fat emulsions. If there were representatives of the companies who sell this in the room, they would stand up and cry and said they would be very discontent with this. But this is definitely my opinion in this. It's never been demonstrated in these patients. There are some data in postoperative patients which we don't give parenteral nutrition, but not for the critically ill patients. For the proteins here, or amino acids, Anne-Berit alluded a little bit to this. For healthy individuals, World Health Organization recommend 0.8 grams per kilogram. For sick people, the ESPEN, for example, recommends 1.1 to 1.5. But a lot of discussion today of even higher levels of protein, but there is definitely no evidence. There is also rather poor evidence for this 1.5. There's basically two studies that are in the literature that are prospective and randomized. This one is nitrogen balance. It's an old study from part of Sweden. I was not a part of it. And basically you can see from here it's nitrogen up there, but it comes to approximately 1.5 and then it levels out. The other one is a case series from Auckland, New Zealand, Graham Hill's group. It's not randomized, but they had the neutron activation, and these are surgical patients who stay in the initial phase of their hospital career in the ICU, and later on they were discharged. And here you see the body cell mass. and the three groups here are just given that level of protein for some reason, not randomized. And the case series says that it levels off at approximately 1.5. So this is the background why we recommend a little bit higher And basically there is little objection to this, but recently there has been a lot of argumentation that you should go even higher up, which is, to make a long story short, not evidence-based. Studies like this comes up. It's from Copenhagen. Allingstrup and co-workers, and these are also case series. These patients were given different levels of protein intake, 0.8, 1.0, 1.5, and then at the end of the day they had differences in outcomes. And this is a hypothesis generating study. This makes us think perhaps it's better, but it's not conclusive in the way that these patients were not randomized to these levels. There were reasons why they were given, and usually patients who tolerate nutrition do better. Very welcome. And for enteral nutrition here we use standard formula, and there is again variability in the content of the macronutrients and the protein to kilocalorie ratio. And in this branch you have a lot of suggestions of so-called pharmaconutrition or immune-enhanced nutrition or whatever. And to make a long story short, there is no evidence whatsoever that this makes any good for critically ill patients, so they cannot be recommended. We do not use them. For fat and proteins here in the enteral nutrition, I would say that there are the same, could be spelled better, same considerations as for parenteral nutrition. What do we do then if they are on parenteral nutrition? Come to us, we reduce it by 50% straight off, and we consider if it's not possible really to give enteral nutrition. And we have to decide something, and there is very little evidence for this group of patients in hospital admissions to the ICU. How should we treat them? This may, to some extent, be used. This is the study from Gordon Doig, which had early parenteral nutrition. He selected a group of patients which were, that was, according to somebody at least, a contraindication to enteral nutrition. So they had to be fed by parenteral route, at least day one. And they were given then parenteral nutrition, or they were not given anything. And they start up like this. You see the kilocalories here. The standard care, eventually they were given something by the enteral route, and then you have the other group here with early parenteral nutrition, and they had a kind of step-up protocol for this. To make a long story short here, and to cite Gordon's, basically his conclusion is that there was no difference between this group. He detected small differences. There was no negative effect of the parenteral nutrition given the way that he does. And you may look at the level of calories here. He is definitely not overfeeding his patients in Australia. And so you can look upon this different ways. You can look upon it that it didn't make a difference. You can also look upon it that it didn't do any harm. In the type of patients that he recruited, the shortcoming of Gordon's study is that it was done over a long period of time in many units, and if you calculate a little bit, the participating units would at a certain time point have less than one patient included into the study. So it was, in that sense, a rare event for the individual units to have a patient included in this particular study. But this is something like the patients that we are discussing up here. Then we come to the panic study. Now Anne-Berit spent a lot of time on it, and I would not extend that. Still, you can't pretend that this study don't exist in many ways. It definitely showed that on a mortality basis there is no difference in this large patient material. And the interesting things here are subgroups, and the most interesting subgroup, according to me, is the one at the bottom here. Surgical contraindications for enteral nutrition, 500 patients. This is a quite large group of patients which were not possible to feed by the enteral route. And the result in that subgroup of patients out of the large study is not different from the whole. So basically, these patients were not fed at all except for 1 liter of 5% dextrose during the first 7 days, and they didn't see a difference, at least not in Leuven. Then we give glutamine in our unit, but I will not discuss that, as that is Mette's topic. So I may ask you questions afterwards. If they are on a combination of enteral and parenteral, we put away the parenteral, we continue the enteral, and we consider glutamine. If they are on enteral, we continue the enteral and consider the glutamine. Now, if they are emergency unit admissions, then and no nutrition ongoing, we start 5% dextrose, and that is basically prescribed when they come to unit. We give it at 40 mils per hour, which means that they will get 1 liter per 24 hours. And the background for that is that the nurses will not give insulin unless we have this 5% dextrose going. We add some vitamins and trace elements to that as well. And then we consider enteral nutrition. And the early enteral nutrition, I mean, just like Anne-Berit pointed out, that there is a total agreement that we should give enteral nutrition. And still, I agree to Anne-Berit that the evidence for this are very weak. For post-surgery patients, there is definitely demonstrated that early enteral nutrition post-surgery is usually a good thing. But is it a good thing in the ICU? And somebody put forward the question, it's usually not so easy. Patients are circulatory compromised, unstable, or under resuscitation, or what? Our good friend Gordon Doig did a meta-analysis published in, if I remember correctly, 2009, and where he basically concludes that there is an advantage for early enteral nutrition. But you can see on these meta-analyses that the studies are small. The literature he reviewed was 115 in each group, divided up on 6 different studies. And then he saw an advantage for early enteral nutrition. But in his conclusion, which I didn't copy in, he says that this is very, very weak evidence, basically. This is the literature that was, but it calls for more studies, and the studies aren't there, basically. We still don't know how much we should push this early enteral nutrition, how early it should be. What we actually do in our unit is that as soon as we have secured airways, we start enteral nutrition. I come back to that in the chart that I showed to you. Yes, and if we don't give enteral nutrition, we reconsider it daily on the rounds, and on day 5 we add parenteral. And then we come back to the studies here, the panic, the SPN that Mette wanted to push for, and the early parenteral from Gordon Doig. We come back to this evidence, and there aren't 2 people who interpret these studies identically, so there is lots of rooms for interpretations for everybody. I'd like to add the study which came up on my email. It's in Clinical Nutrition. It's not yet published in an issue, but it's available on the homepage of Clinical Nutrition. It comes from John McPhee's group in Scarborough in northern England. And John and his friends here, they have taken out patients who have a contraindication for enteral nutrition. They are not ICU patients. It's 15 in each group, if I remember correctly now, 100 patients divided into 2 groups. And there was just a minority of them who were ITU patients. Most of them were not ITU patients. But as they often have in the United Kingdom, they have a nutritional team which basically was contacted. And these patients who were, for some reason, which is maybe just the opinion of somebody, not suitable for enteral nutrition, they were consecutively randomized to 100% or 50%. They weren't measured by indirect calorimetry or anything, but still. And the results that they demonstrate here is more complication in the 100%. I think we need these types of studies. Criticism is, of course, they were overfed and so on, but if this is the criticism, then it's a touchy business how many calories we actually give to our patients. And I think that we must be impressed, and then suddenly stating that basically you don't need indirect calometry because it's expensive or something like that, then that comes very, very funny, basically, because if you do harm by giving 100%, I think in this particular study they gave 28 kilocalories per kilogram, then if you do that, if you do harm by doing that, then there is a problem. And if we go with Anne-Berit's slide here, this do no harm, then we have to consider this. At least these patients in Northern England were better off by giving 14 kilocalories than given 28. Then you may say, I don't give 14, I don't give 28, I give something else. But I mean, these are the types of evidence coming up. And I think this is an important study because it holds some qualities in some respects, although you can criticize other points of it. We come to our chart. We have enteral nutrition, and the rest of it now is going to how we administer enteral nutrition. We do it to anybody who, unless we have a fight with the surgeons about some leaking anastomosis or whatever. And we start with 25 mils per liter an hour, 25 mils per hour. At least it's my opinion that to give less is basically no idea. And then we negotiate with nurses, and nurses like to do retention measurements. So they do retention measurements every 6 hours. And then we will evaluate if this is going fine or this is not going fine. And then you have retention here, less than 200, 2 to 500, more than 500. And less than 200, then we just continue and increase by 25 mils and up to the target, which we defined by kilograms or by indirect calometry. We continue to measure retention at least for some time. If they have more retention, then we pull it back. We continue with the 25, if that's when we started, and make a no retention after 6 hours. More than 500, we return 200 of it, continue with the same velocity, new measurements, and then we continue according to this, basically. And science behind this is poor. There are studies which say that you don't have to do retentions, that you don't get more complications in terms of ventilator-associated pneumonias or aspiration pneumonias or whatever. But I think it's problems to persuade at least our nurses. And I live in a country, even if I as senior consultant and the head nurse said you should do this, if the nurses don't think so, this will not happen. You may live in other countries, but this is what happens where I live. And then it's much better to try to negotiate with the nurses something that they would like to adhere to. And this is what the agreement, basically, that they do these checkups every 6 hours, and then we adjust. So you can call it a nurse-driven protocol, basically, although it's... you see at the end, we waste some of the returns if they continue to have a very, very large retentions. But it's rare, basically. This protocol meant that we were much more overall successful. We don't use any kinetics in our unit. People may think differently about the evidence for this. When I read the evidence, I find very poor evidence, so we just don't use it. So every day, we calculate the caloric balance. I don't know if Mette will include this. She usually does. And I think it's very, very important to have a registration system where you basically get this caloric balance, and to have the nurses to sum up fluid balance and caloric balance after each shift. Otherwise, this will not be successful. So I think this is very important. Indirect calometry, we do it. There are several nurses and doctors who can do it. Not all can do it, but we basically put a lot of attention to this in our unit. And I think there is no other way out of it. Still, we have the problem if we should give in the initial phase 100% of what we measure. I think there needs much more research on this issue. And that's why there's a study from Scarborough and other studies come in, if how important this is. Always consider enteral nutrition if there's, for some reason, haven't started enteral nutrition. And sometimes, just like the questions, we think that patient is unstable, we think that splanchnic circulation may be compromised by pressors or whatever, then we may hesitate a little bit. I just very short on the D-peptides. We nowadays have a screening instrument, so we measure it and we give it to patients who have lower than normal, lower than 500 micromoles, and we check it up, and so that's how we handle it. And we always give it intravenously, and we give it in a dosage that is aiming at normalizing the concentration. This is how we do it. We start parenteral nutrition supplementary on day 5 if needed, and then we have this more pharmacologic doses of selenium. I may come back to that, and we reduce it after some time. But we give it to all patients. We don't find any indication of harm for that. I can discuss that also to some detail. I thought of stopping there and giving room for some questions.